Good morning. Here we are again, Chapter 10, Nursing Care of Women with Complications After Birth. We think it's supposed to all go smoothly and perfect, and unfortunately, sometimes things just go sideways. Most of the time, things that were just happen naturally, and sometimes we could have done better or prevented things. So we're going to get into this chapter and discuss it. Okay, so our objectives are describe signs and symptoms for each postpartum complication, identify factors that increase a woman's risk, and explain measures that reduce a woman's risk. We're going to describe the medical and nursing management of postpartum complications. Super important to know all that. Explain general and specific nursing care for each complication. We need to know how to deal with each one, right? Compare and contrast mood disorders in the postpartum period. That gets pretty freaky. Okay, so let's talk about childbirth. Just in general, most women who give birth recover uneventfully. Thank goodness that's what we see for the most part. But some experience complications. And most of the complications are related to shock, hemorrhage, thromboembolic disorders, puerperal infections, postpartum, subinvolution of the uterus, and mood disorders. So we'll get into all this. Okay, shock. Super scary. Can happen pretty quickly. It's a condition which the cardiovascular system fails to provide essential oxygen and nutrients to the cells. Usually it can't. It's having a really hard time keeping up with what's going on. So cardiogenic, just like it sounds, cardio, which affects the heart, right? Pulmonary embolism does, anemia, not enough circulating hemoglobin that carries the oxygen, hypertension, or cardiac disorders. Some of them are previously known by the patient. Some we find out, again, during pregnancy and delivery when so much volume is involved and changes in the cardiovascular system. Hypovolemic, obviously low volume, postpartum hemorrhage or blood clotting disorder, anaphylactic, allergic response to anything that might have been given, and septic, a puerperal infection. Okay, hemorrhage. It complicates 1 in 100 deliveries. And for a vaginal birth, we've talked about this, but it's considered a postpartum hemorrhage if there's 500 mils of bleeding or more, and 1,000 is over 1,000 for cesarean birth is considered hemorrhage. So early hemorrhage is within the first 24 hours, late between 24 hours and 6 weeks postpartum. So postpartum hemorrhage, the average size woman has 1 to 2 liters of added blood volume during pregnancy, which for the most part is supposed to help, but it can also overtax the heart. But that's why they can tolerate 500 to 1,000 mils of blood loss. Then normally you and I, without being pregnant, goes into the hospital. That could be detrimental to us, but for a pregnant woman or delivering woman, they can handle that because they have that extra volume to lose, okay? Which totally makes sense. But the danger of this shock is that body compensation can mask the signs until it becomes life-threatening. That's why when we get more into this, we're going to see that the pulse is super, super important in all this. And vigilance early on is the key thing to do. Okay, anyway, major risk is hypovolemic shock when you lose too much blood. It interrupts blood flow to the body's cells, prevents normal oxygenation, nutrient delivery, and waste removal, so we can start getting into some complications with blood gases, all that, right? Signs and symptoms. Tachycardia, usually first sign of inadequate blood volume. Remember, blood pressure, fall in blood pressure is a late sign. Yes, well, you will see falling systolic blood pressure, but we don't want to wait for that. Let's catch it before we see that. We can see pale, cold, and clammy skin, they might get, when you see a woman truly losing all that blood, they start getting disoriented, they start asking weird questions, or they just lose consciousness. And of course, decreased urinary output. The kidneys are not getting oxygenated, so they aren't able to do their job. That important blood volume is getting shunted away from the kidneys to help the other organs. Okay, causes of postpartum hemorrhage. This is not going right along with the book, but again, a slide that I liked. Early uterine atony, remember atony, atone, no tone, and lacerations. Late is retained placental fragment or subinvolution, which of course we'll talk about way more. So in this picture, it shows, the first picture is poor tone. See, the uterus is not clamped down to stop that bleeding. Retained placenta is a huge one. So that third picture there, you can see a little piece of retained placenta. It's usually a little fragment, or can be a piece of the amniotic sac that is left in there, and the body is desperately trying to get rid of. Now it's considered a foreign body. So the body is desperately trying to get that out, so it just bleeds and bleeds trying to get rid of it. And then on the right hand side, tears that we may not see inside of the cervix, of the vagina, inside the uterus. It's usually cervical or uterine. Okay, hypovolemic shock. Oh, and by the way, postpartum hemorrhage is a leading cause of postpartum death around the world. So it became the CMQCC, if you ever get a chance to look that up, any of you who are doing your project on postpartum hemorrhage, it's a collaborative, but if you type in CMQCC, it's California, they did a whole toolkit on postpartum hemorrhage, and that has made a significant change across the United States in dealing with postpartum hemorrhage, and it has lowered our statistics of death rate. Okay. So hypovolemic shock. Again, we know this is low volume. It occurs when the volume of blood is depleted and cannot fill the circulatory system. It just cannot keep up. If not corrected quickly, the woman can die. Body's response to hypovolemia initially, the heart rate. Think about it. Let's critical think this. Your heart is going to start pumping faster to get that whatever oxygenated blood it does have to where it needs to go quickly. So that's why tachycardia is the first thing you see. And respiratory rate, it's this complicated part of with your carbon dioxide and oxygen. So your respiratory rate's trying to breathe in oxygen as fast as we can to get that oxygen to the hemoglobin to get through the body. So think about what the body's trying to do by doing that. That's a compensatory mechanism. So purpose of the response, again, increase oxygen content of the red blood cells, which carry the hemoglobin, and speed up circulation of remaining blood in the system. Blood pressure shows narrow pulse pressure, so the falling systolic, rising diastolic readings, blood pressure changes, again, are a late sign, and you always need to know that. Blood flow to non-essential organs gradually stops, shunts away, goes to the heart and the brain. Skin and mucous membranes become pale, cold, and clammy because it's not getting the oxygenated blood that it needs. Tachycardia, first sign of inadequate blood volume. So just remember, as blood loss continues, flow to the brain decreases, resulting in mental changes such as anxiety, confusion, restlessness, and lethargy. You see someone super restless or confused, there's something going on usually, and it's either blood loss or it can be a fluid embolism, restless, or a true pulmonary embolus. Restlessness is a huge one. Sometimes the patient doesn't even know they're acting restless, and you walk in and you look at a whole different patient than when you walked in 15 minutes ago. So as blood flow to the kidney decreases, again, they respond by conserving fluid. So that's why your urinary output decreases and eventually comes to a stop. That's why keeping an eye on your output, your urinary output, can tell you, uh-oh, something's going on in that body that we need to pay attention to. Okay, safety alert. Because postpartum women often have a slow pulse rate, suspect hypovolemic shock or infection if the pulse rate is greater than 100. Now, one thing I want to say about that is look at your trending. If they look at your prenatal record. If they ran 100 in the office and that's their norm, or 90s, then this may not be too significant. What this means is it's a yellow light. Look at it, make sure there's nothing else going on. See if it's the norm for that patient. But if it's slowly increasing the tachycardia, then we really need to pay attention. Okay, so management of hypovolemic shock. This is, again, remember the star is a slide I've added so nobody's confused, but we are on page 248. So we've got to figure out what is the cause. Where are they bleeding from? What is going on? Stop that blood loss. Start IV fluids to start increasing their volume. Always monitor vital signs, of course. Provide supplemental oxygen and insert an indwelling Foley catheter, especially with a urometer, so we can see to the drop how much output they are having. Okay, immediate medical and nursing interventions. Again, stop the blood loss, obviously, but sometimes that's hard to do because we got to figure out where it's coming from and why. So the IV fluid is to maintain circulating volume and to replace the fluids that are being lost. Giving blood transfusions to replace lost erythrocytes. Giving oxygen so that we saturate whatever red blood cells we have in there, that we can saturate it and the hemoglobin so that whatever's going out has enough oxygen on that red blood cell to oxygenate, if that makes sense. A pulse oximeter is used to assess O2 sats of the blood, which is super helpful for us. And of course, the catheter and uterine massage and administration of drugs to contract the uterus. You don't mess around, and the thing is most of these medications that you give for hemorrhage are not harmful. Now, always, of course, Methergin, keep this in mind, and I think we get into this later in the chapter. Methergin is one of those ones that you don't give in fact, I know it is, it's on your quiz. We don't give Methergin because to patients that already have high blood pressure, and we'll get into that more of why coming up. Again, nursing care, always frequent vital signs. I mean, sometimes you're doing them every 3 minutes. Observe closely for early signs of shock. Once people get into shock, you start having shutdown and it's harder to get them back. So watch for those signs early on. Monitor O2 sats, assess lochia. Are we having a lot of lochia or having no lochia? Is it building up in their uterus, right? What's the level of the fundus? So if you have a firm fundus, and know this, you guys, know the difference between a not clamped down uterus versus a laceration somewhere. So if you have a really nice firm fundus and it's at the U or below, then we need to be thinking about a vaginal or cervical laceration that can be bleeding. Obviously, accurate measurement of INO and monitor IV fluid therapies. Monitor for signs of anemia. You may want to put one of those little red top tubes up that we'll talk about on the wall and see how the clotting's going. And explain things to the patient as best you can if they're coherent. And the family. This is terrifying when we start just throwing everything at them. So you might have to make it short and to the point, but tell the patient what's happening. I liked this slide on anemia, so I added this. Occurs due to loss of erythrocytes. So the patient may complain of being dizzy or lightheaded. Think about minimal oxygen carrying cells going to the brain. That would make you dizzy or lightheaded. May be advised to continue with iron supplements for several weeks postpartum, which we absolutely do. Lots of times we give IV iron before they go home because that makes an amazing difference in their anemia. So on the left, I just wanted you to see the difference. There's many red blood cells, normal hemoglobin. On the right, anemic blood, fewer red blood cells that are circulating the oxygen, and lower hemoglobin on those cells. So, question number 1. First sign of hypovolemic shock is most often? Everyone better answer tachycardia. Yes, number 4. Okay, so just remember too that when that uterus is nice and firm, but we're still having those signs of hypovolemia shock, it may also be a hematoma, which we will look more into, but we've discussed hematomas. And remember, they can be hidden. They can be inside the vagina, they can be on the labial wall, and they can fill up fast. And you would be amazed how much blood there can be in one hematoma. And then remember, if you have the occurrence of petechiae, remember petechiae, there's little pinpoint, little bruised looking spots on people's skin, or bleeding from a venipuncture site, or oliguria may indicate blood clotting issues. They could be going into DIC. So those are all things as an OB nurse you need to be very aware of and keep track of. Okay, so early, which is also called primary postpartum hemorrhage, again, causes uterine atony, no tone, lack of normal muscle tone, lacerations or tears of the reproductive tract, and hematomas in the reproductive tract. I liked this picture on the right. It shows a tear in the cervix, and those suckers can bleed. So you see how they're visualizing with these retractors, and they're visualizing inside the mom's vagina. This is the cervix, and see how they're suturing it up to stop the bleeding. Sometimes they go back to the OR and get the patient in a twilight thing because this can be pretty painful. Think about opening all the patients just had a baby and they're messing around with everything down there that's already so sore and they're exhausted. So sometimes we take them to the operating room and you can get better visualization when they're not in as much pain. Okay, so remember uterine atony, no tone. So what happens is the postpartum uterus is a large hollow organ. We've just delivered anywhere from usually a 5 to 10 pound baby through there. So now it's huge and hollow, and it has 3 layers of muscle. The middle layer includes interlacing figure 8 fibers. The uterine blood supply passes through this network of muscle fibers to supply the placenta. So that just gives you a little bit of a visual of what we're looking at. So what happens with uterine atony is the inability of that myometrium layer, that muscle, to contract and stay contracted around those open blood vessels. Our body is meant to clamp down and cut off those open bleeding areas. You know, our platelets should go there and start healing, and the clamping down tamponades it, but something happens that makes that not happen. So mechanical factors include retained placental fragments, large blood clots, extreme uterine distension. What if they just had triplets? That muscle is not going to function right. And a full urinary bladder. Metabolic factors, muscle exhaustion due to lactic acid buildup. What if they pushed for 4 hours? They held their breath with every push? Think about all that. Hypocalcemia. Think about the role calcium plays in muscle cells. And then drugs. If the patient is on magnesium sulfate, if they're preeclamptic, they stay on the magnesium sulfate for 24 hours after delivery. So it's that smooth muscle relaxer. So we're fighting against that. And of course, calcium channel blockers. Remember your calcium going in and out of the cell, things like that. Okay, so uterine atony usually causes a collection of blood within the uterus. So after the placenta detaches from the uterine wall, the uterus normally contracts and muscle fibers compress those bleeding vessels. If uterus is atonic, without tone, right, muscle fibers are flaccid and do not compress vessels at the placental site. So it allows the blood vessels at that site to bleed freely and massively. So we got to get on it fast because you just cannot believe how much blood they can lose every minute. So again, causes uterine overdistension, retained placental fragments, prolonged labor. That uterus isn't going to work as well if they have a prolonged labor. Or use of drugs during labor that relaxes the uterus. So what if we had to give terbutaline because they were having too many contractions? What if we had to give magnesium? All those things matter. So I wanted you to see these pictures of how the muscle wall works. So on the left is that big hollow organ, the uterus, after the baby is delivered. See how big it is? And that uterus has come off, or the placenta has come off that wall of the uterus. So on the right, blood vessels get compressed by that uterine muscle. On the bottom, underneath, see how big those little vessels are? Because they're not being compressed or tamponaded. And see on the inside the uterine cavity, then there's that little space, the bleeding, because those vessels aren't compressed. So the 4 T's always are tone, tissue, trauma, or clotting, a coagulopathy that makes them not. What if they had low platelet counts to begin with? What if they had an idiopathic thrombocytopenia, low platelet count, things like that that we're dealing with. The bottom right picture, the uterine atony. See on the top part, it shows that uterus nice and clamped down, and see how it's tamponading in there? That uterus is kind of looks like it's folding in on itself. Well, the bottom right-hand picture is showing a uterus that's not clamped down. And look, it is just bleeding and bleeding and bleeding. That's why we massage, get that uterus clamping down. Okay, so normal postpartum changes. After birth, the uterus should be easily felt through the abdominal wall. That's where we go to the fundus and we press down. So we should feel a mass about the size of a grapefruit. And I always take the patient's hand and I place it on there and I say, feel that nice big, I always say a ball in there. You want that ball. If you don't feel the ball, rub till you do. Think about it, it's a muscle. So when we mess with muscles, they start spasming and clamping down, right? And that's what we want to have happen. So after the placenta is expelled, fundus of the uterus is usually at about umbilicus, so at U, begins descending 1 finger's width, which is approximately 1 centimeter each day. Rubra should be dark red. Remember, rubra is the first few days of the bleeding. Should not saturate more than 1 pad per hour. Few small clots are totally normal. It's when you start passing lots of clots and it doesn't stop. Okay, so I just wanted you to see, it's a little blurry on the top left-hand picture, the full descent of the uterus for each day postpartum. Uh-oh, I lost it. Shoot. So again, I can't seem to go back on this, but you can look at the pictures and see for yourself. Sorry, don't ask me why. It has a back arrow and it will not let me go back. Okay. So characteristics that we'll see if there's atony going on. Difficult to feel, or when you do finally find it, you're really rubbing that fundus, it's soft, and you rub, and then you feel it firm up. And then you know, wow, it was really boggy, okay? Fundal height usually found above the umbilicus. Of course, if bladder is full, we're gonna find it to the side, and we immediately have them empty their bladder or use a catheter if they can't void. And the uterus is usually higher because that bladder is pushing it out of the way, right? And again, a full bladder not only pushes it to the side, but it interferes with that uterus's ability to clamp down. Loci is increased, may contain large clots. True amount of blood being lost may not be immediately apparent until she stands up. You just can't even believe sometimes. You're like, okay, we need to get you up to the bathroom to go pee. We're having a hard time keeping this uterus calm down. And let's get you up to the bathroom. They stand up and all of a sudden all these clots and blood come out, which is usually a good thing because some of the clots you've been trying to get out didn't realize there was an issue until they stood up, didn't know it was clots in there. So lots of times that really helps, but if it keeps on coming is when you get them back to bed and go through your whole procedure of meds and fundal massage, things like that. Collection of blood in the uterus further interferes with contractions. So that's why we've got to keep on that uterus and that fundus and make sure it's not filling up. Okay, so what do we do when we find a uterus that's boggy? Well, we combine nursing and medical measures. Sometimes just massaging can do the trick and teach the patient to massage. I always say, anytime you think about it, I want you rubbing your tummy and feel that hard ball. But when the uterus is boggy and it gets firm, by the way, one other thing to let's say about that uterine massage, fundal massage, is just don't overly massage. And if you become an OB nurse, you'll find a fine line there, what's overly and what's not. But remember, again, the uterus is a muscle, and excessive stimulation can actually tire it out and make those muscles be dysfunctional. So if the uterus is firmly contracted, leave it alone, okay, below you or at you. All right, so again, bladder distension can be a big cause. So the uterus is massaged to firmness, bladder empty, and then treatment can be putting the infant to breast. Remember that sends out the oxytocin, clamps down the uterus. We can give oxytocin in their IV or as a shot if they don't have IV, Methergin and or Cytotec. Methergin, again, you have to be careful if they have high blood pressure. You don't give Methergin. Cytotec is given rectally. Dosage is 800 to 1,000 micrograms, where if you're inducing a patient, it's 25 micrograms to start out with. So you can see it's a drastic difference, and you need to know those differences so you don't accidentally give too much. Okay. Okay, so I'd just like to reiterate, because of its importance, postpartum hemorrhage is one of the #1 things you'll see and used to be one of the #1 causes of death. So we've got to know our stuff. So a lot of times LVNs will work postpartum. These are good things to know. So assessment and management of the hemorrhage. Monitor vital signs, INO level of consciousness. Be alert to the signs and symptoms of atony. The soft, boggy uterine fundus that quickly loses firmness after massage. So you've got it spasming, and then when you stop, it stops spasming, okay? Fundus that is not midline or above at the level of the umbilicus, excessive lochia, or excessive clots. So if you start thinking, geez, I don't know if this is too much, you weigh the peripads or weigh the chucks that they're on. And 1 gram equals 1 milliliter of blood. So it's super simple math. The first nursing action, of course, is to massage the fundus until firm and express any clots that could be in there. Lots of times the doctor will have to come back in, reach his hand up in there, and clean out any clots that may be in there that we just can't express. You got to be careful when doing too much pressure that we don't have a uterine prolapse. So you've got to be very, very careful about that too when you're really pressing on women's funduses. Thank goodness, rarely is a hysterectomy ever needed. I think I've seen it twice ever. So there are all kinds of things we can do now to prevent that versus what we used to see 20 years ago. So lacerations of the reproductive tract, and it can occur on the perineum, the vagina, the cervix, and around the urethra. Some women get tears right up into their urethra. Vasculature bed in these areas are already engorged with blood. Blood is usually brighter red than lochia and flows in a continuous trickle. That is the #1 cardinal sign of it being a laceration versus boggy uterus. Is you have a nice firm fundus and you just have this steady trickle of blood. It's not even always a big trickle, but it's steady. You can't get it to stop no matter what. And the fundus is firm. So always think lacerations when the fundus is firm and you're having bleeding. So treatment is usually suturing. We've got to find that tear and suture it. And if you're having an emergency issue like this, postpartum hemorrhage, or you're just concerned about it, any inkling of an idea that the patient may have to go back to the OR, do not give them any food or fluids. You're just going to set them up for aspiration. Remember, trauma can be a huge cause of the lacerations. If there was forceps used, vacuum, anything that can cause a little tear along that, the vagina, any of those places. Okay, now we're looking at hematomas of the reproductive tract. So a hematoma, collection of blood within tissue. Birth trauma, usually on the vulva or inside the vagina. Usually, and you're going to see a picture in a minute, it's like this bulging bluish or purplish mass. Looks like this huge bulging bruise. And it causes patients terrible pain. Lots of times they'll go, it's really uncomfortable down there. And it's not just from the delivery. You can tell they're a little restless, and it's just something really hurts. And usually they feel pressure down there, the vulva, pelvis, or rectum, and they may be able to unable to urinate because of that pressure and the fullness in there. But they may not have unusual amounts of lochia. So kind of keep that in mind, because they're having bleeding inside this tissue. It's not from atony of the uterus. Again, watch for pulse and respiratory rate to rise, and then late sign blood pressure falls. So here's some pictures I found. I know they're pretty disgusting, but I wanted you to see what they truly look like. So on the left, you can just see where they can get these hematomas, and look how full they can get. It's unreal. They can have 1,500 mils in them sometimes. And think about that. 1,000 is for a C-section, 500 postpartum hemorrhage. You get a hematoma growing to 1,500. We literally had that happen one time. They took her back to the OR, and it was a 1,500 mil hematoma. That was more inside type 1 than here on the labia. So the first picture of the labia, you can see that is a swollen with a hematoma labia. And on the right-hand picture, that's a labia. It's just with a smaller amount of swelling hematoma. But they're still painful, and we've got to make sure they don't continue to fill up. So just remember contributing factors to the getting the hematoma: prolonged or rapid labor. A really large infant can cause tears coming through there. Use of forceps or vacuum extraction. You can see, look on the left, the forceps, putting those up inside. Think about the vaginal walls and through the cervix, okay? And then the vacuum extraction, sometimes the part of the vacuum gets hooked on the cervix, different things. So you have to think about those things when there's any instrumentation that have gone inside. Treatment. Small hematomas usually resolve without any treatment. You just treat it with ice, any kind of invasive treatment, let's put it that way. Usually we'll put ice on it, tux, dermoplast. Larger hematomas may require incision and drainage, but think about this. If we haven't found the source of the bleeding, we got to stop that source of the bleeding before we drain them so it doesn't just fill up again. So if we find the source is a bleeding vessel, it may need to be ligated, or the area can be packed with, hemostatic material. And again, ice pack is usually adequate for small ones. So late postpartum hemorrhage. This is, sometimes we see it in the hospital, but usually it's they go home and all of a sudden they start this weird bleeding. It's bleeding that occurs 24 hours to 6 weeks postpartum. It's usually caused from retention of placental fragments. The body wasn't fighting it off until it got home. Or subinvolution of the uterus, which we'll talk about. So placental fragments are usually what causes it. There's that retention. I had this happen. I was in the hospital 5 days after a cesarean, and a few days after I got home, hemorrhage during the night. Went in and they found just a teeny tiny little piece. They did a D&C of amniotic fluid sac. So they're most likely the cause because it doesn't cleanly separate. So clots form around these retained fragments and slough several days later, sometimes carrying the retained fragments with them. So retention of the fragments is more likely to occur if the placenta is manually removed, which that happens with cesarean sections. Every once in a while, a vaginal birth, it has to be manually removed. Not very often, thank goodness, because the body has a way of releasing it. But in the operating room, the doctor manually tears it off, and it's literally taking it off the wall of the uterus. Okay, so it's being removed by hand rather than being pushed away from the uterine wall spontaneously from the contractions of the uterus. So these placental fragments are also more likely to exist if the placenta grows more deeply. So those are things like accretas, that the little tentacles grow deeper into the wall, the first layer of the uterine wall. So treatment is administration of drugs such as oxytocin, methergin, or prostaglandins, carbaprost, hemabate. Those are things we give if we need to contract down that uterus. So firm uterine contractions often expel the uterine fragments and no treatment is needed. Sometimes we do an ultrasound to see if we see anything in there. And then what happened to me is they do a curettage. They scrape or vacuum the inner surface of the uterus. And so basically they just clean out that whole uterus again. D&C is dilation and curettage, and D&E is dilation and evacuation. So they use this suction on there. Antibiotics are almost always used so that they, because there's a lot of stuff going on inside that uterus and we don't want any infection to happen, okay? So just think this though. So subinvolution means that it's not happening well. It's not contracting down correctly. So what's involution? We talked a little bit about it before, but let's review. So involution is the return of the uterus to its non-pregnant condition after birth, primarily caused by sudden withdrawal of estrogen and progesterone. Decrease in hormones cause release of the proteolytic enzyme, so lytic, right? You know what that is, into the endometrium, the lining of the uterus. So it causes protein material within the endometrial cells to break down into substances that are excreted in the urine. Look at all this. Think this critical thinking. Okay, all the things that are needing to happen in involution and what's happening with subinvolution. So with involution, though, the number of cells don't change, only their size. So muscles of the uterus contract and constrict blood vessels at the placental site, stopping the bleeding. That's what's supposed to happen. Uterus should not be able to be palpated by 12 days postpartum. If it is, something's going on. Again, I loved these visuals. Involution, again, begins after expulsion of the placenta. The body goes into this, what do we do now? And says, okay, we need to stop the bleeding. So the placental site contracts to a size less than half of its original size immediately after birth. Contractions cause uterine muscles to act as like living ligatures and compress the blood vessels. And that's what it's showing you on the right-hand side. Those ligatures that are compressed, supposed to compress those vessels. So when that doesn't happen normally, that's when we start seeing subinvolution of the uterus. Slower than expected or failure of the uterus to return to its normal pre-pregnant condition. So again, normal rate of the descent of the uterus is 1 centimeter per day, or 1 finger breadth. Signs and symptoms of subinvolution: fundal height greater than expected, Persistence of lochia rubra. Remember, it's only supposed to last 2 or 3 days. If a week later they're still having rubra, something's wrong. Pelvic pain and heaviness, fatigue. So factors, again, that can slow the normal involution. Remember, star, star, star. So it's one I added, but we are on page 252. Prolonged labor, again, muscle exhaustion, incomplete expulsion of placenta and membranes, anesthesia, depending on how much they've had and what kind, previous labors. So if they've had 5 different kids, previous children, then their uterus can be just so stretched out and dysfunctional. Distended bladder, blood clots that are stuck inside, and of course that boggy uterus. Nursing care of these women. Teach normal changes to expect. Before they go home, we go over all this and we give written instructions, printed out instructions, what to watch for. Okay, so usually they are discharged before it shows up, because think about it, if rubra lasts 3 days, usually women who had a vaginal birth stay 48 hours. So we're not going to think anything of them still having rubra. Report abnormal patterns such as fever, pain, persistent red lochia, foul smelling discharge. Are they getting infected in there? Comfort measures. Talk about what they could do. Prepare for possible surgical intervention, so the D&C, D&E, and explain medications that are prescribed, why to use them, and what meds we need to use. So again, just helping you understand these subjects a little bit better. Retained placenta. It can be big chunks of it. Some women have a placenta, a normal placenta, but it has this little lobe that comes off of it, and it's almost like a string attached to this little lobe. So the placenta comes out and you think, okay, we're done. Placenta's out, it's intact, it doesn't look like any pieces are missing, and we move on. Well, we didn't know it had a little lobe in there that hasn't come out yet. Okay? So if there's any of those pieces in there, it prevents the uterus from contracting effectively. It tries, and it can contract some, but not always effectively enough. So oxytocics given to expel fragments of the placenta, again, may require the D&E or D&C. Placenta accreta may result in profuse bleeding and may require hysterectomy. Again, cretas, accreta, increta, percreta, those are where those tentacles go through the wall of the uterus. Accreta goes through the first labor. I can do this. The first layer of the uterine wall. Increta goes deeper into the second layer. Percreta can literally, again, those little root system can go all the way through and attach to things inside the peritoneum, such as even the bladder. And think about the surgery that's going to happen after that, and the mother can die. So here on the right hand side is just showing normal decidua, then accreta that goes through the first layer, up here to the right, increta, and then percreta all the way through all the layers of the uterine wall. So you can see how dangerous that would be, especially if it's unknown. They can see most incretas and percretas on ultrasound. Accretas get missed some because it's usually just through that first layer. Okay, so this slide isn't in your book, but I just thought it was kind of an important little tidbit to understanding how everything works with releasing of the placenta after delivery. So, exfoliation. Unique healing process that allows healing of placental site without scarring. So, necrotic tissue is sloughed off. Reparative process ensures future fertilized ova will implant in an unscarred uterus. So this is not manual release of a placenta. This is spontaneous release. This is what happens. Then the endometrial regeneration is complete within 16 days postpartum. Placental regeneration is complete at 6 weeks postpartum. So the part where the placenta was, it once it releases, there's these enzymes that go in and fix it all and make it all nice and pretty for the implantation of the next pregnancy. And that's what they're saying about the scarred uterus. If you have C-section where there's manual removal, this process doesn't happen, or it doesn't happen nearly as well. And then when next pregnancy and then next pregnancy and next pregnancy, that fertilized ova is trying to find a spot that's not scarred. Well, what if it implants right next to the scar? And as that fetus grows, then it can go, okay, wait a minute, part of this feels like scar tissue. I've got to dig in deeper. And that's when you get the accretas, incretas, percretas. And that's why this process is so important, and what gets missed when there's a C-section or a manual removal. So I've also read a study the other day that says that in the OR, they're trying to now, a lot of ORs, I don't even know if ours is yet, this is so new, let spontaneous release of the placenta instead of manual removal, so we have less problems in future. Anyways, I just thought this was interesting for you to kind of understand how it's supposed to work. All right, now we're on page 253, and we're talking about thromboembolic disorders. It occurs in 1 in 1,500 pregnancies, thrombosis, blood clot, right? Size of the clot can increase as circulating blood passes over it and deposits more platelets, fibrin, and cells. So that's how it gets bigger. It catches on to that initial clot. And then it causes inflammation of the vessel wall. And so that's why patients have pain and redness at the site. Okay. So again, venous thrombosis is a blood clot within a vein. Causes or risks are venous stasis. So if the patient's bedridden and the blood's not moving really well, it's static, right? And during pregnancy, if they're not very active, or what if they have a desk job and they sit at a desk and the backs of their knees keep getting pressed on? Or during labor and delivery, their legs are in stirrups. We don't use the old stirrups, but we still use leg support things, but they don't put a lot of pressure on the back of the knee. But a lot of hospitals still do use them, and a lot of old-fashioned doctors still love them. So fibrinogen, which is what we want a lot of in pregnancy, it's normal to have a very high fibrinogen rate for the fact that patients bleed afterwards, things like that. So with that being said, fibrinogen levels increase during pregnancy, whereas clot dissolving factors in the blood are normally decreased during pregnancy. So you can see how that can cause a bit of a conflict and some issues. And then varicose veins. A lot of women get varicose veins from the pressure of the weight of the pregnancy. So you can see these pictures down at the bottom. The left one is showing you a possible blood clot. See how it's swollen and it looks red? And on the right is varicose veins. And some women get them horrible. They can get varicose veins even on their labia. It can be ugly. And then on the right-hand side is just showing the formation of these deep vein thrombosis, how the blood flows through these, and then they can clot together. Okay, so there's different types of thromboembolic disorders. First one we're going to talk about is SVT, superficial vein thrombosis, or like a phlebitis, right? They usually are painful, hard, reddened areas, and the vein may be warm, and they might have a slight temp elevation. DVT is deep vein thrombosis, and that's the one that's characterized by the pain, calf tenderness, positive Homan sign, leg edema, color changes, pain when walking. So you want to keep track of if their leg is increasing in size, right? So you need to get leg circumferences. And a greater than 2 cms increase accompanied by redness, tenderness, and edema should be promptly reported. Because what happens when one of those breaks off? It can turn into a pulmonary embolus, right? That's the free-flowing type. Okay, so pulmonary embolism, so scary. I had one patient with it, and she had a C-section for a ruptured uterus at 22 weeks. And yes, the baby passed away. And I was taking care of her post-op, and I lost her IV. It just infiltrated. And I'm like, oh man, she's sick. And she'd been in the hospital a day. Then during the night, they found the baby was extruding through a opening in the uterus and did an emergency C-section. I got called in for it. And so I took her over at 7:30 the next morning. You know, I'd worked with the baby during the night, which passed. But then I took her over as my patient at 7:30. And so I lost the IV, and she was just puffy and just pale and grayish. And she all of a sudden looked at me and she said, Stacy, I feel like I'm shutting down. I said, yeah, no, I think I told you guys parts of this story, but I'm just going to reiterate. And I said, we got to get your IV going. We need to get those IV fluids going and everything. And she goes, no, I'm shutting down. And she was in the medical profession, so she knew what she was talking about. So, of course, that freaked me out. Got RT in there. Her pulse ox was 56. So can you imagine getting a 56 on a pulse ox? That was one of the scariest moments of my life. So, of course, got the doctor, everybody in there, called a code. They did a mainline right there in her jugular, right in the room, because she was get out of it now. And I kept looking under the cloth to see, you know, the drape, to see if she was still alive. We're still in her room at this point, by the way. And all of a sudden her lungs started filling up with fluid. So the doctor says, give Lasix. And I'm like, I don't have an IV. And he goes, no, through your central line. I was like, oh my God, I've never done that before. But the anesthesiologist was right there, and he said, push it fast. And I literally could just hear her lungs clearing out without Lasix. It was unreal. But her pulse ox was still low, so we ran her down to CT scan. And sure enough, there was a pulmonary embolus. But it was small enough that it didn't block it enough, the arteries, to cause death. So that's what saved her. And she ended up in ICU. And I don't know if they did an embolectomy or if they used medications to dissolve the clot, because she was in ICU after that. But anyways, you get somebody with a pulmonary embolus, it is a scary, scary day. Okay, so again, one of the three leading causes of maternal death. The other two are hemorrhage and gestational hypertension, preeclampsia. So embolism can occlude vessel and obstruct blood flow into lungs. Pulmonary artery is obstructed by a blood clot that breaks off and lodges in the lungs, which that's when they may have to go in and do an embolectomy. So signs and symptoms: chills, hypotension. My patient had hypotension, dyspnea. She didn't say anything about chest pain, but a lot of people do. Cough. I could just hear her lungs with every breath filling up with fluid. Decreased level of consciousness. She definitely had that. Tachypnea and apprehension. She definitely had that. Signs of heart failure. Well, think about her pulse ox being in the 50s. Small pulmonary embolism may have shortness of breath, palpitation, hemoptysis, faintness, low-grade fever. You don't mess around if you think this is any of the things that are happening. You've got to act fast. So management. So if you have the SVTs, rest, anti-embolus, TED hose, analgesics for comfort, elevation of the leg, frequent ambulation to help prevent clots from forming. If you get the DVTs, you usually give them anticoagulation therapy such as heparin, and local application of heat, elevation of legs, and anticoagulation, early ambulation if it's possible. And of course you keep up on their labs and make sure if their PT, PTT, and INR, all bleeding factors are getting better or normal or not getting worse, right? Okay, so classic symptoms of DVT include muscle pain, positive Homan sign, and swelling of the affected limb. True or false? Hopefully you all said true, because that's the answer. Okay, so what do we do for these people to prevent a thromboembolism? Well, we watch, which is kind of a weird topic saying watch, because that's not preventing, that's figuring out if they're having it. But again, dyspnea, coughing, chest pain, increased temp. Teach a woman not to cross her legs as it impedes the blood flow. Avoid pressure behind their knees. Early ambulation, we do those anti-embolic stockings and the SCDs in the hospital, sequential compression devices, right? If they're had surgery and laying in bed. Up to the right, you guys probably know about these. There's the knee ones below the knee and the thigh-high TED hose. And of course, report any positive Homan sign. Anticoagulant therapy. So there's danger signs with, think about it, you're thinning their blood, so they could bleed more. So we've got to teach them the danger signs, which is they cut themselves and it doesn't stop bleeding. Nosebleeds, unexplained bruising. We teach them to use a soft bristled toothbrush so they don't have too much damage in there. Stress the importance of completing follow-up blood tests. That's super important. And help them cope. Explain that this is short-term. This can be fixed. This doesn't cause long-term problems usually. And, give them reassurance. Because anybody who hears clot gets scared. You hear people having strokes and dying from blood clots. Instruct the patient that vitamin K is the antidote for a warfarin overdose. So if they're on those anticoagulant therapies, vitamin K should be on hand. Okay, now we're moving on to infection-puerperal sepsis, so after delivery. So an infection or septicemia after childbirth with a fever of at least 100.4, that's the mark we always tell patients when to call the doctor, 100.4. After the first 24 hours and for at least 2 days during the first 10 days postpartum. Risks, how do they get this sepsis? Well, cracked nipples. Wide latching is so important. Think about that. Having those cracks, warm, moist nipples and the baby feeds. And bacteria loves to climb in that spot. Surgical incision. Tissue trauma during labor. What if they had big tears? What if they had skid marks? Anything that's open for bacteria to get in. And again, open wound at the placental insertion site that hasn't closed off yet. Retained placenta or blood clots, or increased pH of the vagina after birth. It's can be an issue. It's not killing the bacteria, right? If your pH is higher, it's more alkaline than acid, right? So that means it's not killing as much as the bacteria. Then there's this endometritis, inflammation of the lining of the uterus. So blockage of the lochial flow can cause it, but also this, oh, I had a good statement about it, just a second. Give me a second here. Okay, so the fever most often caused by the endometritis, right? So the danger of postpartum infection is that a localized infection of the perineum, vagina, or cervix can ascend the reproductive tract and spread to the uterus, fallopian tubes, peritoneum, causing peritonitis, which is a life-threatening condition. So that's why we need to prevent any portal of entry or protect those portal of entries that are already open, like where the placenta was taken off, and keep bacteria from forming in there, right? From gathering in there. So endometritis, signs are tender uterus, enlarged uterus, prolonged severe cramping, foul-smelling lochia, fever, and signs of involution. Here's another one I found on endometritis that I liked. Infection of endometrial lining, decidua, and adjacent myometrium, one of the layers of the uterus, correct? Symptoms begin 2nd to 5th day postpartum. Uterine tenderness and enlargement is one of the signs. Again, foul odor or purulent lochia. Malaise, fatigue, tachycardia. They just aren't feeling good. Something's wrong. And temperature elevation. So you can see on the right that inflammation, that's where the uterus, see how inflamed it is there? And then that yellowish stuff, infection, the lining of the uterus. Okay, so I love this. Wash hands, you must. Get sick, we have no time for. It's true. Do whatever we can. Prevention is the best medicine. So, associated risk factors with this infection. Physiologic changes during pregnancy increase the risk. Again, we have decreased acidity of the vagina. We have amniotic fluid, blood, all that stuff going on. Increased growth of pathogens. What if they have premature rupture of membranes and have been sitting in the hospital for 3 days with an open portal there? Most women do not get an infection because of granulocytes in the loci and endometrium, but some people do. So prevention, meticulous adherence to aseptic techniques, hand hygiene and perineal care, minimize vaginal exams. That, again, portal of entry. Every time we put a glove on and put it in there, think about it. It's a sterile glove, but we're going through a dirty vagina. It's considered dirty in there. And so we're just putting it right there at the opening of the uterus for it to go right on in and make its little home in there. What are the dangers of puerperal infection? Well, there are definitely dangers. So a localized infection of the perineum, vagina, or cervix can ascend into the reproductive tract and spread to the uterus, tubes, and peritoneum. You get a patient with peritonitis, it can be very life-threatening. So labs should always be evaluated, of course. White blood cell count is always an important thing to look at. And 30,000 day after vaginal delivery, assess patient further. Because for the couple days after delivery and during delivery, their WBC counts can be normally high, so it can be a little deceiving. So WBC count of 20 to 30,000 is normal in early postpartum period. So that's why they're saying if it's above 30, definitely act on it. If it's below 30 and nothing else is going on, then you don't have to pay as much attention. But if they're getting feverish, things like that, then of course you still do. Okay, safety alert. Proper hand hygiene is a primary method, of course, to avoid the spread of infectious organisms. Gloves should be worn in contact with blood, body fluids, or other potentially infectious materials. I liked this cartoon. It said, I spent 2 years in nursing school. There was 3 months of anatomy, 3 months of clinical, and 18 months of learning how to wash our hands properly. It's true. It's amazing how much focus is on that, but it's true. We need it. Okay, nursing care, of course. Our goal is to prevent the infection from occurring. So, hand hygiene, adequate rest and nutrition. You know, protein counts for a lot for nutrition, for healing. Teach and observe for signs and symptoms of infection. And teach them how to correctly apply their perineal pads. Think about it. We tell them wipe from front to back. Well, they should remove their peri pads, apply their peri pads front and remove from the back. And teach them to take all their antibiotics if they're prescribed them. And nutrition, super important. Mastitis. Boy, I've heard from people who've gotten mastitis how miserable it is. Just so uncomfortable, and they feel sick. And look at it. The picture on the left is starting a mastitis. The middle, they've got mastitis. The right, it's not only mastitis, it looks like it's actually getting like abscessed. It's unreal. So, of course, it's an infection of the breast. Signs and symptoms are redness and heat in the breast, tenderness, edema, and heaviness of that breast. Purulent drainage could happen from the nipple, and it can be just disgusting. And fever, chills, they almost always have a fever. They spike a temp if they get mastitis, and an abscess could form. So I liked this extra one, but we are on page 255. So mastitis usually occurs around the 2nd to 3rd week after birth, although I've had them in the hospital starting to come down with mastitis. Interlobular connective tissue of one breast is usually involved. Occurs when organisms from skin or the infant's mouth enter small cracks in the nipples or the areola. And the cracks can be microscopic. We may not know they're there. Breast engorgement and inadequate emptying of milk are associated with mastitis. Again, think about that warm, moist environment that bacteria loves. Painful or tender localized hard mass. Sometimes it's in those milk ducts or a reddened area. Fever, chills, malaise. Again, causes are nipple trauma, poor breastfeeding techniques, and inadequate hand washing. Okay, so what's our treatment? Antibiotics and mild analgesics usually. Continue to breastfeed. And we'll talk about that a little bit more. If they have an abscess, then usually you have them pump. But if it's one side, feed on the other. If there's not abscess and it's not too bad, like those first two pictures you saw, the baby still should breastfeed. We need to empty those breasts. So believe it or not, that doesn't hurt the baby if it's infected. Abscess gets a little bit different, but those are rare, okay? The thing you need to know, and I think it's need to know for quiz, is begin all feedings with the unaffected breast, then the other side if it's not too painful. Empty both breasts with each feeding. Pump if you have to. Pump and discard the milk from the affected breast if there is an abscess. So when it comes time to weaning the baby, it can lead to engorgement and stasis of milk, which can worsen the infection. So we have to keep that in mind when we're helping people wean from breastfeeding. So heat promotes blood flow to the area, so we always suggest warm showers before the feeds. Massage the area of inflammation to improve the milk flow and reduce it just sitting there, the stasis. Encourage a lot of fluid intake. Let's really get the infection pushed out. Wear a supportive bra, but not the underwire bra, and provide emotional support. They feel underwire, the wire just kind of presses on all that and can make things worse. So again, mastitis prevention. Mothers should be taught proper breastfeeding techniques. So we had twins a week ago, and I was absolutely honored. The twins started having some issues. They were preemie, and she was just little, and I had worked with them a full day on breastfeeding. And she was in the emergency room with the baby, and one of our nurses went down to help her figure out what was going on with the baby. They still aren't quite sure. The O2 sats kept dropping. But while she was there, she started feeding the baby, and it was so awesome because the nurse told me later that the patient was putting the baby on, and such a cute little thing, and she got her to latch, and the nurse said she started talking to the baby and saying, "Oh, no, 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 that's not the proper latch. Stacy wouldn't approve of this latch." And then she said to the nurse, "I went through Stacy's breastfeeding boot camp." And it's just true. I am a fanatic about getting them latching correctly to begin with. You have much more success with breastfeeding down the road if you can get that. The patients don't get sore. You have less risk for infection. There's so many reasons why we need to start it off right. So empty both breasts, pump breast to ensure emptying. That I just put there the different kinds of pumps you can see. And there's electric, there's the bulb, there's the hand pump one, wear the supportive bra, relieve pain, and take the shower. Okay, so here's another question for you. A woman develops mastitis in the postpartum period. She states, "I am so sad I have to stop breastfeeding my baby." How should the nurse respond to that? I'll give you a minute to read them. Okay, hopefully you answered number 4. It is not necessary that you discontinue breastfeeding. In fact, we usually tell them not to discontinue it. We've got to keep that milk flowing, and the baby can still get its breast milk. Okay, now we're on page 256, mood disorders. This can be very complicated, and it's become quite the issue in the OB world, because they're finding that so many women, it's getting missed in their prenatal care. Now they've even, the state or some institution, governmental institution, has said that they need to do these depression screenings. There's different forms out there that offices can use so that these women don't fall through the cracks. Because how many women like to admit, oh, I'm so depressed, oh, I have terrible thoughts. So sometimes women keep it hidden. They feel it's a sign of weakness. So we need to figure it out and help these people. So mood is a pervasive and sustained emotion that can color one's view of life. And anybody who has suffered through any depression or mood disorders knows what that feels like. So baby blues, postpartum blues, super common after birth. We've talked about this. You're boo-hoo-hoo, but you're happy. You're like, I don't know why I'm crying right now. And your body's insane right now, going through all the hormonal changes and trying to get back to normal. And mother has periods of feeling where she feels let down, but overall finds pleasure in her new role as a mother. It's usually self-limiting as the woman adjusts to her new role and her body adjusts to everything else. So the blues. It's also known as adjustment reaction, okay, and it occurs about 75% of women, so it's pretty common. It's a transient state, comes and goes, right? Rarely lasts more than 10 days. After childbirth, estrogen and progesterone levels decrease rapidly, which can lead to increased brain levels of MAO/A, which can affect our mood center, and it's related to onset of postpartum depression. So they may complain of feeling overwhelmed and unable to cope, maybe oversensitive with periods of unexplained tearfulness. This is where a woman just needs help. If they're feeling overwhelmed, have a family member take the baby for a few hours. I've done this with friends and family, and tell the patient, go lay down, get a good nap. I'll bring her in for feeds, whatever the case may be. Sometimes they just need direction or permission to get a break. So again, treatment is rest, anticipatory guidance, empathy, reassurance, support, and assistance. We need to be there for these people. So I liked this. It says, don't confuse postpartum depression with baby blues. So doctors have coined the term baby blues to describe a 2-week period after giving birth when mothers feel stressed, overwhelmed, anxious, fatigued, and mildly depressed. Different from postpartum depression, these symptoms tend to fade after 2 weeks. So it's kind of how you can differentiate. So postpartum depression is when it's going a step further than the blues. There are 3 types of postpartum depression: adjustment disorder, postpartum mood disorders, and postpartum depression. So postpartum depression is a depressive illness that usually manifests within 2 to 4 weeks postpartum. Include signs such as weight loss, they can't sleep, they're ambivalent towards the care of the baby. May interfere with her ability to read the baby's cues and bond with that baby. Affects 10 to 20% of postpartum women in the U.S. So that's a high number, and we need to pay attention. So postpartum depression usually strains the coping mechanisms of the entire family. Think about a dad coming home from work or significant other, whatever the case may be, and the woman's depressed, hasn't done anything with herself, the house, the baby, and they're all adapting. What do you do? How do you help this person? And as a result of the strained relationship, communication is often impaired. The depressed woman may withdraw further, which distances her even further from her support system. They usually, with the depression, stay in touch with reality, but it could sink them deeper into worse things. So women at high risk have unstable or abusive family home environment or history of previous depressive episodes. So here's some just little examples of postpartum depression. Again, risk factors for it are inadequate social support, poor relationship with partner, life and childcare stress. What if they have to go right back to work and haven't found someone good to take care of the baby that they trust? Low self-esteem, unplanned pregnancy. It's all so overwhelming. Low self-esteem. Think about how women look right after birth. Sometimes we're not the prettiest pictures. So you look in a mirror, these women, and go, oh my God, who am I? So this is some typical conversations that can happen. A friend is saying, how are you? Fine. Inside, she's like, I'm overwhelmed, I'm terrified, sleep deprived. I'm sorry I had this baby. Not really. I mean, I love my baby, but I don't feel good. I don't know what I'm doing. I can't think straight. Don't even recognize myself. Don't feel like myself at all. I'm irritable all the time. So, but she tells her friend she's fine. So again, we need to watch body language cues and tell patients, don't be afraid to tell people. It's a chemical imbalance that needs to be helped. And then here's a husband saying to the wife, do you need anything? Nope. But what she's really saying is, I need a home cooked meal. I need a shower. I need a break. I need time to myself. I need sleep. I need someone to understand how I feel. Sometimes I need rest, help, food, hugs, support, cookies, quiet, nourishment, help with laundry, cleaning, cooking. I need acknowledgement, understanding, and support. But how many partners pick up on that? Some are fabulous and don't even need to pick up on it. They automatically do it. And I encourage the partners, when you get home, don't expect her to do it all. Her body is going through a lot right now. But most of us just say nope because we're the strong woman. We're going to be the best mother on the planet, so we can do it all. Where we need to tell these people, if someone offers up help, take them up on it. Okay, another question. Postpartum depression is an expected reaction following childbirth. True or false? It's false. Postpartum depression isn't expected. Postpartum blues is. So read questions carefully if you got that wrong. So again, the signs to watch for if your friend or family member or wife or significant other has these signs, get help. So lack of enjoyment in life. You see mothers out there, they're so happy taking their babies for walks and things, are the ones that are just staying in bed all day. Lack of interest in others, intense feeling of inadequacy, unworthiness, guilt, inability to cope. They're sitting there going, I love my baby, why am I so unhappy? Loss of mental concentration, inability to make a decision, disturbed sleep or appetite, constant fatigue, and feelings of ill health. So the nursing care for this, one of the things that we need to be careful about is being alert to the possibility of self-harm by that woman. Depression can lead to those things. Light therapy is awesome. I took a class on it one time, and it's people who are inside too much, things like that. So I really encourage my patients, go out and get some sunshine. Even if you're just sitting outside in the sunshine, soak up that vitamin D, and that light therapy can make an amazing difference for some people. And then, of course, that's one of the CAM therapies. There's those other ones out there. So the influence of hormones or mood change before, during, and after menstruation support the theory that fluctuating hormone levels postpartum may also have an effect on the woman's mood. So there's a lot of reasons this can happen to a woman. She just needs to know what to do when it does, if it does. So we would refer her to a multidisciplinary team. Depends on when this happens. If it's at home, usually the doctor has all the resources to send them to. May need to be prescribed antidepressants. And a lot of women are very resistant to that, but usually it can be short-term with this type of thing. Not always, but can be. We need someone to be a sympathetic listener for her. Explore her feelings. What is she feeling and what can we do to help her? Observe for complaints of sleeplessness or chronic fatigue. The mother's expressions of feelings should be pursued to help her express them better. Get the social worker up there if you're worried about a patient. Have them talk. They know how to do that therapeutic talk. Provide that support. Help women identify her support system. Suggest things. Do you have a neighbor? Is your mother? Is there anyone who can come help you? Determine if the mother's getting enough exercise, sleep, and nutrition. And help her identify ways to meet her own needs. And there's support groups out there for people like this too that can be amazing. I liked this too. Postpartum depression really hits you the day they turn 30, don't have a job, and still live at home. That's when a lot of postpartum depression hits for a lot of people these days. Okay, postpartum psychoses. Now we're getting into women having an impaired sense of reality. This is scary. Thank goodness the psychosis is much less common than depression and blues, but it happens. There's two psychiatric disorders that are most commonly encountered. It's bipolar disorders, and it's usually characterized by episodes of mania, major depression, deep feelings of worthlessness, guilt, sleep and appetite disturbances, delusions about infant being dead. You hear these stories, and I even use this as an example when I'm teaching my students, discharge teaching. You know, I say to the husband or significant other, you lots of times can be the one to see what's going on. Sometimes a woman starts just sinking into a pit and they don't even realize they're sinking. So if you see these things, and what mother wants to say to their spouse when they come home from work, oh, hey, honey, I had thoughts about throwing the baby out the window today, or I wanted to stab the baby to death, or I wanted to drive off a bridge and both of us drown. What mother would willingly say those things to somebody and have people look at them like, oh my God, you're crazy, right? But this is real. And these are things that we have to understand and know the differences and what to do about it, because it can be fatal for both mother and infant due to use of poor judgment. You hear these mothers drowning their children, driving them in the water, things like that. They are, most of them aren't criminals, they're sick. So again, postpartum psychosis is the most severe form of postpartum psychiatric illness. It is a psychiatric emergency that requires immediate intervention because of the risk of infanticide and suicide. Incidence is 1 to 2 per 1,000 women after childbirth, and it can occur as early as 48 to 72 hours after delivery. Pretty scary. So we need to be aware and help these people. So again, the risks are suicide or, thoughts or actions of actually killing their child. We need to refer them to counseling, and something that we need to teach our patients, virtually all antipsychotic medications pass through the breast milk. Therefore, they can't breastfeed. But psychosis is a whole different scenario than depression and blues. And you have to weigh what's best for that mother and baby. The nurse's role, what do we do? Again, this is one I added, but we are still on page 257. Provide support and referral, encourage her to express her feelings, provide validation, address personal conflicts, things you've had in your past that make her feel better about it, that can reinforce personal power and autonomy. A woman's culture, experiences, and coping strategies influence her adjustment. And above all, listen to what the woman is saying verbally and with her body language. Okay, homeless mother and newborn. It's lack of a permanent home. It isn't always that they live on the streets, but it's lack of a permanent home. They could live in motels with friends. They can couch surf or extended family. They often have difficulty accessing care. They don't have rides. And follow-up is difficult. And oftentimes they're very afraid of CWS coming to take their baby. So prior to discharge, ensure mother has a place to go and a way of accessing help. Facilitate referrals to outreach programs, support services within the community. That's where we get social services involved, and oftentimes hospitals have like a chaplain's fund that can help with those kinds of things. Sometimes they get vouchers, and they can assist with low-income housing, things like that. So if we find, which most hospitals now do a screening for homelessness, if we find that's the case, then we need to be acting on it and get social services involved. Okay, that's the end of chapter 10, and I just want to remind you guys to review the key points. That's always super helpful, as are the questions at the end are very helpful to know how the questions are going to be worded and what we need to do. And have a great rest of your day. Be talking soon.